First of all, thank you for giving us that doc, Dr. Hind. I think you guys are doing a great job. We were just back from Oman last month. We did the training for all the primary care physicians in obesity medicine to help optimize your National Diabetes Center obesity. So I think you and Dr. Noor are doing an amazing job. I was really blown away with the multidisciplinary teams that you guys have created. And I understand completely the challenges that are going on because we do share them in the region. The second question that you asked Dr. Haidar about the dulaglutide versus the liraglutide, the Victoza. The dulaglutide actually does not have as much weight loss the once a week as compared to the Victoza. They didn't do head-to-head studies, but if you look at the data on the dulaglutide regarding weight loss versus the data on the liraglutide has much more weight loss as compared to the dulaglutide. So I would never advise someone to go on dulaglutide as opposed to liraglutide for weight loss. So I'll end that. I'll start my talk. I'll talk about approaches to surgical failure, the weight regain, and inadequate weight loss after bariatric surgery. My full disclosure is that I am not a surgeon. I am an endocrinologist who specializes in obesity medicine. So I will not preach to the choir here about surgery. When I give talks to non-surgeons, I usually go a little bit in detail about the surgeries, but here I will just do my thing. These are my disclosures. And I'll start by a little bit of a background about fat mass regulation. So we do know that blood, for instance, is regulated by the body. When someone goes and gives a little bit of blood or donates a little bit of blood, what ends up is that your body regulates your blood mass and you never go anemic. Same thing happens with the liver. When someone donates their liver, you guys are all surgeons, you do know that although the liver probably doesn't grow in the same shape that it was previously, yet it does keep its same mass. The thing is, the same thing actually happens with adipose tissue. So adipose tissue or fat mass in the body is regulated by a very complex system. And what happens in obesity is that fat mass set point goes up, and that is the definition of the disease, and that's why patients develop obesity as a disease. And what we do is the challenges that we face to treat obesity is to reduce back that fat mass point from a higher fat mass point to a lower fat mass point. So this is what usually happens with patients. I'm hoping this clicker works. Okay, it does. So this is what usually happens in regular life. You have a predetermined fat mass set points. We all have that. And then what happens due to environmental factors, aging, patients or people, we all gain weight as we grow. What happens with surgery is when you do surgery, you reduce that fat mass point down. So the fat mass point, the whole curve is actually shifted down to the downwards, and then when, with environmental influence, aging, patients do gain weight. It's expected to gain weight, but they never go back to that original fat mass point that they had. So I'll start with that, and then I'm going to talk about obesity treatment strategies. So when we talk about obesity treatment strategies, I always think about it as a stepwise approach. I think about stage 1 as being microenvironmental targeted therapy, and I'll talk in detail about that. That's lifestyle and everything that entails sleep, circadian rhythm, and all of that. And then I talk about stage 2 being pharmacotherapy. And then after pharmacotherapy, what we end up doing, or what everybody ends up doing, is filter a number of patients, and that's what that lines determines is a filter. And then those patients, go to weight loss surgery, which is stage 3. But then what again happens after weight loss surgery? And that's what I'm going to be talking about today. So this is just data from the Swedish obesity subject study, and there is so much data to back me up. Probably bariatric surgery has some of the most robust and best data that we have in the literature regarding surgery. There is no question that bariatric surgery is the most effective way of treating obesity and reducing that adiposity set point that I talked about earlier. So when we talk about surgical failure, and just to clarify, because surgeons tend to take this to heart, and I completely understand that, surgical failure is not the failure of the surgeon by any means. All the surgeons that I have worked with have been brilliant surgeons. Surgical failure is really, is the failure of other things that we'll be talking about in this talk. So the most common one that we see a lot is patient that undergoes surgery and then they regain the weight, and that's type 2 surgical failure, which is weight regain. And then we have type 1 surgical failure, which is suboptimal weight loss after bariatric surgery. I'll talk about type 1 first, which is suboptimal weight loss after bariatric surgery. And just before that, I'll talk a little bit about what happens generally in patients. So this is a patient with obesity. They undergo diet and exercise and caloric deficits, which always doesn't work, and that's why I never talk to my patients about caloric deficits. They have short-term weight loss, and then metabolic adaptation kicks in. And we know from the studies from Kevin Hall and Rudy Leibel and all of that metabolic adaptation is just so very strong. Increased hunger hormones, decreased satiety hormones, decreased energy expenditures by very complex systems that causes weight regain. And then the patient keeps on going into this very vicious cycle all their lives. They undergo metabolic surgery, and what metabolic surgery, it alters the neurohormonal regulation and reduces the adiposity set point. And then what happened? We have sustained weight loss after metabolic surgery. That is what we expect to happen. But what happens sometimes is we get this suboptimal weight loss. So suboptimal weight loss, I've put in this curve because this is a wonderful curve that shows that the people respond, or patients respond to surgery in a normal distribution curve like they respond to any other treatment strategy that we have. So there are people that respond in average, which are most people, and this is excess body weight loss as compared to the percent of patients. And then we have people on the far left side of the curve who are non-responders or suboptimal responders. These are the ones that I'm going to talk about now, type 1 surgical failures. And then we have the ones that we love our patients to be in, which are on the very far end right of the curve, which are the super responders. So when we talk about the non-responders and super responders, Lee Kaplan and his group went into the lab and they wanted to determine how can we get predictors for those? Can we tell patients that if you do surgery, you probably won't lose as much weight as you hear you're going to lose, or what we expect, this is what you're going to lose. And they looked at those predictors. So these are the predictors that they came up with. A higher initial BMI predicted less suboptimal weight loss. If you had limited physical activity, if you had diabetes prior to going into surgery, if you had a lower education level, and if you missed your appointments, you probably will have suboptimal weight loss. But when they looked at the percent, how much did that contribute? It was only contributing to 40% of the suboptimal weight loss. So where did the other 60%? Why couldn't we explain the other 60%? So they went back to the lab and they did a great study where they looked at, they had more than 800 patients. They looked at patients that were first-degree relatives that underwent Roux-en-Y gastric bypass. They looked at patients who lived with other patients who had a Roux-en-Y gastric bypass, so they were living, that's the co-inhabitants, and they looked at patients that were unrelated, and they compared them. So interestingly, what they saw is that if you cohabitated, or if you had bariatric surgery and you lived with someone who had bariatric surgery, your weight loss basically is the same. So living with someone with bariatric surgery, having the same behavioral habits would not change anything in your weight loss. But if you had a first-degree relative who had bariatric surgery, who had success, you will succeed in your, or who had failure, you will fail in your bariatric surgery. So that's why every time when my patients show up to my clinic, before I send them to my surgeon, Mohammed Abu Khater, what I tell them, I ask them, did anyone in your family undergo bariatric surgery? If they say yeah, I ask if they're successful or not, and I say, please expect that what's going to happen most likely is that your response will be very similar to your first-degree relative's response. So the genetic factors actually accounted for 70% of the variability between first-degree relatives in their studies. So they went and they did actually GWAS-associated studies, and they looked at they looked at this allele, and which is on 15q, which is on the chromosome 15q26, and this is in Roux-en-Y gastric bypass, and they looked at the individuals who had copies of that allele. If you had no copies of the allele, you ended up losing 38.7% of your weight after a Roux-en-Y gastric bypass. If you had one copy of the allele, individuals who had one copy lost about 33% of their weight. If you had both copies of the allele, you lost less weight. So patients who had more copies of the allele ended up losing less weight. So what do you do for suboptimal weight loss? We optimize always lifestyle, we introduce specific interventions, and I always think about, when I think about lifestyle, or I call it the microenvironment, I no longer call it lifestyle, I talk about weight promoting medication, which is the most preventable way of weight loss, and then we talk about nutrient signaling, or the type of food that they're eating, not the calories, but the type. We talk about muscle activation or muscle activity. We talk about the hours of sleep, the circadian rhythm, if it's disrupted or not. I talk about chronic stress. All of these will interact with your genetics, your age, your sex, the development, and they'll affect energy regulation. What else do we look at after a lifestyle? We look at either revision, and I'm not going to talk about that because I know there's someone else talking about that who knows revision surgery probably way more than I do. So we just do know that revision surgery really doesn't have a lot of supportive data, and it doesn't really work very well after bariatric surgery. We talk about conversion. We sometimes convert sleeve gastrectomy to gastric bypasses, and so we add a second component to the surgery, such as a duodenal switch. And what I usually do is add complementary medical therapy. Sometimes they're adding medical devices, but there's little supportive data on bands after that. So when we talk about anti-obesity medication, which is mostly what I do, I like to break up anti-obesity medication into adrenergic, anti-epileptic, anti-diabetic, and others. And everything here in green is FDA approved. Everything is in red is off-label use. And when you come to look at this list, actually in the region, and this is what we taught in Oman, is that in the region we have all the drugs except for phentermine. And I think you in Oman are actually, after we talked to them, you guys are actually getting it. And I'm working here, hopefully, to get the same drug here in Saudi Arabia if the SFDA works a little bit more with me. This is a case study that this is an example of one of our patients who underwent a Roux-en-Y gastric bypass, had suboptimal weight loss. Since we have topiramate here in the region, we started her on topiramate, and what you can see here is she had 36% excess body weight loss with surgery. When we added topiramate and escalated the dose, she had a 19% excess body weight loss in addition. So surgery combination therapy had a 55% excess body weight loss in combination. So that's regarding suboptimal weight loss. I'm not going to go into more detail because of time constraints today. We're going to talk about weight regain. So what is weight regain? A lot of studies showed that about 30% of patients experience weight regain in 2 years, and about 50% experience the weight regain in about 5 years. There's no clear definition of weight regain. Some papers have defined it at more than 10% from the 10 kilograms from the nadir. Some papers have defined it as 25% of excess weight loss of regain. There's a lot of definitions. So the data is a little bit murky, and it's not really clear on what weight regain is. What we know is that there are different results for different surgeries. If a patient undergoes a sleeve gastrectomy or a Roux-en-Y versus a Roux-en-Y gastric bypass versus a one anastomosis gastric bypass, there's a difference in weight loss between the surgeries. There's inconsistent definitions of weight regain from literature, and there's always a mismatch between what the patient perception of weight loss is and what the provider expectation is. So they come to you as a surgeon, and you know they're going to lose about 30% or so of their weight if they get the surgery. But the patient comes back to you after losing 40% of their weight, which is really on the far right of the curve that I showed earlier, and they're still disappointed because they think they didn't lose enough weight. And then what Dr. Abu Khater does, he sends them to me for me to deal with them. But that's for another day. So what happens is you've got the etiologies are anatomical, behavioral, psychological, iatrogenic, and biological. And usually they're multifactorial. It's really not one or the other. So what about anatomical causes? I'm not going to preach to the surgeons here. With adjustable gastric bypass, we know that there's inadequate band adjustment. We know there's a pouch enlargement that can happen. We know there's slippage of the band that can happen. With a Roux-en-Y gastric bypass, there is a GG fistula that really we don't see as much of it right now because we're doing laparoscopic surgeries as opposed to the old days where we used to do them as open surgery. So there may be some pouch dilatation, some stoma enlargement. With vertical sleeve, there's a sleeve enlargement. So those are mostly the causes of of anatomical causes of weight regain after bariatric surgery. How about behavioral and lifestyle? Again, I'm not going to go through the schematic due to the limitation in time, but it's the same schematic that I go through. Psychological, we talk about binge eating disorder, and emotional eating and mood disorders, and each one of them actually has its specific treatment. With binge eating disorder, we even have medications that actually target binge eating disorder specifically. Iatrogenic, the biggest cause, please always ask about your patients about medications that will cause weight regain, because the biggest offenders are insulin, sulfonylureas. In this region, a lot of antihistamines that we really overlook, that once you stop the medication or you change it to something that is a weight loss promoting or a weight neutral medication, that weight regain will reverse. And we see that all the time in our clinics. And biological. When you talk about biological, weight regain may be neurohormonally mediated, just like weight loss is. But there's really no long-term data on the hormones that affect weight regain. We have some conflicting data on ghrelin, PYY, GLP-1s. And it may be related to developmental changes, age-related changes. Women get pregnant after bariatric surgery. Women go into menopause after bariatric surgery. These all may cause weight regain. So patients tend to think about that curve that I showed you at first. That fat mass set point goes down, but patients will regain some of the weight following that. So when you assess someone with weight regain, you evaluate for medication changes and do a lifestyle assessment, change diet, activity, sleep, circadian rhythm, stress, psychological screen for binge eating, mood disorder, stress eating, developmental defect, such as postpartum, perimenopausal women may undergo weight regain during that period that they're going through their development, and consider always anatomic evaluation if there's a high suspicion, such as barium swallows and so. So if the weight gain is rapid and abrupt, think about medication, think about anatomic causes, think about a sudden stressor that has happened. If it's slow, think about behavioral or lifestyle, think about psychological or developmental. And then, so if the etiology is behavioral or lifestyle, do a lifestyle change. If the etiology is psychological, do CBT or psych counseling. If it's iatrogenic, stop the medicine. If it's anatomic, surgical evaluation, or biological pharmacotherapy. And always, always remember, you can actually add meds to every one of these. And this is what we do all the time in our clinics. So when you start meds, and this is a very, very, and because due to time restraints, I'm not going to go into detail into this. You start drug therapy, you go on for 3 months. If they lose more than 10% of their weight, then they stay on the drug indefinitely, forever. Obesity is a chronic disease. Remember that. The treatment for a chronic disease is forever. If they lose 5 to 10%, you continue the therapy, but you add another drug, and there's a slew of drugs that we have here. As I said, it's only phentermine that we don't have. And if they lose less than 5% of the weight, you stop that drug, and then you start a new drug from the list, because that means that drug has failed.
1 minute.
And then you do that. We're done. So we've gotten, we published this out of our center at Mass General and Cornell, and this is our experience. We had patients, 319 patients, 54% achieved more than 5% total body weight loss. This is not excess. 30% achieved more than 10% total body weight loss, and 15% achieved more than 15% with medication post-surgery. This is one of our patients who underwent we started them on topiramate. We went from a BMI of 36 after regain to a BMI of 26 with medication. Philip Schauer and his group just published this year, after our publication, his experience. 37% of patients lost more than 5% in his experience. Dr. Servicita, one of our group as well, published her experience, which is about 6% of her 6% total body weight loss in her group. This is another one with topiramate from our experience here, which shows as well that 64% excess body weight loss. They had 81% regain, so they only ended up with 12% of excess body weight loss. With topiramate, we were able to achieve an extra 48% of excess body weight loss and bring them back. So it's a stepwise approach. So it's microenvironmental, followed by pharmacotherapy. Patient undergo weight loss surgery, and then the very end is post-surgical combination. It's not surgery alone, but it's a post-surgical combination therapy now. I will not go through the summary, because what I'm going to go through is just one thing to say. Please, 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 as surgeons, do not blame your patients if they regain weight or do not lose enough weight. It's really, as you saw, a lot of it is genetic and biological. Send them to your to the MDTs. Send them to your obesity medicine specialist or your endocrinologist, and they'll take care of it. And I'll take questions now.
Thank you. Any question from the floor? Please, Doctor.
Very nice presentation, really impressive.
Thank you.
I congratulate your department who's getting your services here. I think you can add a lot in post-operative weight loss. Do you have any experience of adding metformin immediately after the surgery and continue it versus only bariatric surgery? Because we add metformin, which is presently approved by FDA as an anti-aging medicine, anti-cancer medicine, and now I think endocrine, they say it is a vitamin M now, which everybody can take it. So can we add?
We should put it in the water, along with statin, and everybody should drink it.
Yeah, so if we can add metformin with, that is my experience in last so many years, I add metformin in immediate post-op period whenever they are back to normal diet, and they do well, they lose more weight than their counterpart without metformin.
So metformin can be used as an anti-obesity drug. I tend not to add it a lot post-surgery because of the GI side effects. So I wouldn't know what is from surgery versus which is not. But as you said, when they're back to normal diet, and so that's why even with my patients with diabetes, I do not put them on metformin. I never do after surgery. I put them on insulin because then I don't know which is which, and it becomes very confusing. But it is a very, I mean, there is a post, as I said, because of time restraint today, my talk was so much longer, I promise, and it had a lot more detail. But there was a post hoc analysis in the DPP trial for patients that are metformin responders, and they did very, very well with metformin. So you either get a responder versus a non-responder. Metformin has never been marketed as a weight loss drug because it works in 2 out of 10 patients, but we do use it all the time.
For type 1 patients, when do you start to interfere?
So that's a very good, so I actually interfere when there's a weight plateau for 3 months. Always, when you plateau, so I wait until you develop your new set point. If you plateau for 3 months, I intervene.
So you wait on the patient?
3 months. If it's a plateau, then we intervene. Then it's time. So I have had patients that I have intervened as soon as 6 months after surgery where they have failed. 3 months of a weight plateau, you're not losing anymore, that means you're not going to lose. And that has been our experience, both in my previous institution and on here, because I've only joined this institution now for the past almost 6-7 months, Dr. Mohammed. I think that's as much as I've been here. But for my past experience, it's 3 months. That's the golden time.
And what you do for the sweet eaters, like they develop craving for sweets after a few months of bariatric surgery?
Yes, so you're asking about specifically sweet eaters and cravers.
Yeah.
So sweet eaters and cravers, I always think, I'm always a very opponent of, it is not behavior that drives your biology, it is biology that drives your behavior. So if you are a sweet eater, that means something is going wrong with your basically biology. So there are drugs out there. I use bupropion, I use naltrexone. Naltrexone works wonderfully with cravings if you need so.
Any experience of acarbose?
I do not use acarbose for a weight loss because it's a weight neutral drug. It does not show any effect on. We do use them for dumping syndrome, but we don't use it for weight loss.
Not for weight loss. At least it can reduce the sweet craving. It's a craving.
Naltrexone will be, try naltrexone, if they're not on pain medicine, it'll go away like this.
We'll take the last question.
Thank you, Dr. Nasreen, for this informative lecture. You said in the last minute that you don't blame your patient for regain weight.
Yes.
I think someone needs to be blamed. Either the surgeon, he doesn't know the proper surgery.
The biology is blamed.
Or surgeon or the patient, one of them. Either of them, but sometimes I know this is 30%, sometimes, or say 40% patient can be blamed because they do not understand what post-op should be done, the course and everything, and they don't compliance with the instruction. And sometimes also the surgeon is not doing proper surgery. Sometimes we do sleep.
I've been lucky to have wonderful surgeons, Dr. Abdurrahman.
Yeah.
My surgeons are amazing, all through.
Yeah.
So that's, I understand what you're saying, but I really beg to differ with you. I believe that behavioral does not drive biology. I believe it's biology that drives behaviors. If your patient is not sticking to what you're calling their diet, and that's why I never call it diet, I call it healthy eating. If they cannot eat healthy, then there's something wrong. Then you sit with them and you ask what it is. If it's their biology, if the patient, I always ask my patients who weight regain, and they will tell you, it seems like a switch in my brain has been off. Something like after surgery, I did not feel hungry. Now I'm getting hungrier. They're not getting hungrier because they want to be bad. It's because something's wrong with their biology. So you say, okay, I have something to introduce now that's going to take that hunger away.
I think that the best way for success of bariatric surgery is education. As education, pre-op, I think this is the success key for the surgery. Patients should have everything from day one to pre and post-op, all the detail. And I think this is our part to educate the patient and everything. Probably I think this is the way of success of the surgery.
Okay.
Thank you so much.
Thank you, Dr. Nasreen.
Thank you.
Thank you.